Good afternoon, everyone. Assalamu alaikum, honorable panel of expert, learned audience. Assalamu alaikum. My case is an uncommon cause of atrial fibrillation in a 58 years male. Mr. Y, 58 years, old gentleman came to emergency department with the complaints of shortness of breath for 1 day and palpitation for same duration. On clinical examination, pulse was 130 beats per minute, irregular. Blood pressure was quite normal. Heart sound was variable in nature with no added sound. Lungs was clear. Patient was afebrile. Patient presented to us during the COVID period, and his saturation was quite normal in room air. This was his ECG that showing the atrial fibrillation with fast ventricular rate, and this was his X-ray. This was his X-ray, just which showing some sorts of cardiomegaly. And he was treated with IV amiodarone at his vitals were stable, and patient reverted to sinus rhythm just after bolus dose of amiodarone in the emergency department. Patient was given admission in the hospital. Lab investigation revealed all the lab reports are quite normal, including the COVID-19 RT-PCR. Then the echocardiography was done. On the operational long axis view, it shows the mitral valve and aortic valves are seems normal. And on the right panel, there is the regional wall motion abnormalities. There is quite good in the global eye estimation. On the apical four-chamber view, there shows there is a membrane-like structure in the lower part of the left atrium, and is also evidenced by two-chamber view. And we did the color flow Doppler, and that shows that there is a flow acceleration through the membrane with the eccentric opening in the membrane. We do the spectral tracing showing there is a mild form of obstruction with the peak pressure gradient 6 mm of mercury, with trace tricuspid regurgitation with pulmonary artery systolic pressure around 40 mm of mercury. So we did the 3D echocardiogram to confirm our diagnosis, and he also shows there is a live 3D showing the true view, live end-phase view showing there is a membrane in the left atrium, and it is also true view showing the membrane in the left atrium as evidenced by the 3D echo. So our final diagnosis was code triatriatum sinister with paroxysmal atrial fibrillation. The code triatriatum sinister is a rare but surgically correctable congenital cardiac anomaly accounting for 0.1% of all congenital cardiac malformations. It is a rare congenital cardiac anomaly with a fibromuscular membrane that bisects the left atrium into two chambers. Superior chamber is formed by the embryonic common pulmonary veins, and the inferior chamber is formed by the embryonic left atrium. The CTS membrane can vary widely in size and shape, and its configuration defines the clinical presentation of the patient. Atrial fibrillation has been described in 30% of published cases on adult with code triatriatum. The most common comorbid cardiac condition in adults are atrial septal defect and mitral regurgitation. Cardioembolic stroke has been reported to occur with code triatriatum with and without concurrent atrial fibrillation. And the clot formation in the left atrium shares the similar pathophysiology like the mitral stenosis. Thank you all for patient sharing.